So first of all, I would like to welcome everybody and thank you for joining this webinar today. We are connected virtually today to hear from Dr. Petro Cayoni, his Italian experience on managing COVID patients in critical situations. Just a quick information, we are going to record this session so that everybody is informed that this session will be recorded and you will have access to this in future. And my name is Poonam Rao. I am Marketing Manager for Acute Care Diagnostics in Werfen EMEA. Together with my colleague Abdulla, we are hosting this session along with our local partner Abdulla Fouad. And thank you for everybody for being here. This event is possible only with the collaboration of Saudi Society for Clinical Chemistry in association with Saudi Commission for Health Specialists. So thanks a lot for giving us this opportunity to bring this educational event to the group that is represented with the Saudi Society for Clinical Chemistry. Without any further ado, I would like to introduce Dr. Zaid Kurdi, Assistant Professor and Consultant of Medical Biochemistry, Pathology Department of College of Medicine, King Saud University. So Dr. Zaid will be the moderator for today. After the presentation, we will have question and answer sessions. So feel free to use the chat box to ask your questions and leave your comments there. So over to you, Dr. Zaid.
Thank you very much, Poonam. And hello, good evening, everybody. And welcome for all of you in this, I think will be nice and informative lecture. Since the beginning of COVID-19 in December 2019, the world has suffered from very negative impact from this disease, either socially or economically. A global economic have suffered from the vast recession since the deep recession in 1928. However, this is not the worst thing which the world have suffered or faced. The most important thing is the bad effect on human life, on human health. A lot of things, a lot of procedure, a lot of protocols and work happen in all over the world in this field, all over in all countries in the world. A lot of health professionals work 24 hours, 7 days a week. And one of the most important people who are health professionals who work in the field of ICU and in the field of treating and caring with the COVID-19 patient who have critical cases. In this lecture, we will have Dr. Petro Cayoni, who are working in the Department of Anesthesia and Critical Care in University of Turin in Italy. We are happy to have him in this lecture because of two things. The first thing, that he is from country who suffered from this disease a lot. And after that, I think, and this is true, they have a lot of experience now in the field of caring patients, especially in the field of in patient of critical cases. The second thing, because of this is the CV of Dr. Petro Cayoni. So I think it is very decent CV and has a lot of experience in this field and in a lot of another research field. So I will read some of this CV. As I said, he's an assistant professor from University of Turin, Faculty of Medicine and Surgery, Department of Oncology. In 2000, he has bachelor degree in medicine and surgery The grade was 110 over 110. And I read about this rank in Google and find it. This is the special rank in Italy. That means it is A and A plus grade. Correct me, Dr. Petro, if I'm not correct later, inshallah. And also he has a specialist in anesthesia and intensive care units. Also 70 out of 70 grade from School of Anesthesia and Intensive Care, University of Milan. And during that, he has a research fellowship in anesthesia and intensive care in Massachusetts General Hospital, Harvard Medical School in Boston, USA. He has a participation and points, a lot of certificate. One of them is he was a co-inventor for patent application. The name of the patent is extra corporeal circulation system for the treatment of imbalanced electrolytic and acid-base blood. Also, he is a member of different, more than one master degree scientific committee and one PhD scientific committee as well. He was an assistant professor in University of Milan, and now he is assistant professor in University of Turin department. He has granted or participate. He has granted as a co-author or primary investigator of 14 research projects during his career. Also, he has a lot of about 7 or 8 acknowledgements. One of them from the last one from European Society of Clinical Investigation for his best basic research article. Also, he did review and he is part of editorial board and advisory board for different journals. Like American Journal Respiratory and Care, Critical Care, Anesthesiology, Blood Transfusion, Journal of Medicine, Case Report, Journal of Critical Care, Clinical Chemistry and Laboratory Medicine, and also more than this, another journals. He has a lot of teaching activities. And finally, he has 91 peer-reviewed article published as a co-author or primary author, and 4 non-peer-reviewed. And also he wrote 23 book chapters or monographs or bibliographies entries. So after this long experience, I think this is the second reason why we are honored and happy, because not only we have a lecturer from a very experienced country, but also from very experienced CV and background in the field of research and in the field of ICU. So we welcome Dr. Petro in Saudi Arabia virtually. And I think this is the easiest and the fastest trip to Saudi Arabia you have ever, and you will have.
Absolutely, Zaid. Thank you very much for this kind introduction. I should share my screen if I can. Yes, here I am. Okay, great. Thank you very much. It's really a pleasure for me to be here, and I would love to be there with you, but of course it's impossible during these days, and maybe in the future, who knows. And the second reason for which I'm very happy to be here, and I would like to thank also Verfen for this kind invitation, is also that I really like and love to share our experience on this tragedy, the COVID-19 pandemic, because I think we don't have so much occasion to share with other countries experiences, and also clinical experience and research experience on this really huge problem worldwide. So what I really would like to do in this lecture is to give you some thoughts, some considerations based upon my experience and based upon what I think we know so far of this disease, new disease, and I really would love later on to also to answer and to exchange with you some opinions and experience. So this is my hospital, just a picture of my hospital, and Turin is a large city in the north part of Italy, and my hospital, San Luigi Gonzaga University Hospital, is just outside Turin. Is the second university hospital of this of Turin, of the University of Turin. Is a medium-sized hospital with 400 hospital beds. We have an emergency department, of course, a coronary unit, a stroke unit, several surgical specialties. And before COVID-19 pandemic, we have, and I have in my department, nine ICU beds. And the problem is that right now we are living and we are facing the second wave of COVID-19 pandemic. And let me just, okay. And at this time I had to, sorry. Okay, and during the first wave, I had to increase ICU beds up to 24 beds, and just basically invading coronary unit and operating rooms, because as we will see, we didn't have enough ICU beds for the most severe patients. And at the moment, we have basically the same problem. This is just the situation according to WHO data, updated a couple of days ago. We have more than 1 million deaths so far, and more than 50 million cases. I think that nobody has never thought to live this type of situation, which is a very severe crisis worldwide. This is the situation up to now in Italy. As you can see, I can use my pointer option. Oh, here we go. Here we had the first wave, and of course, during the first wave, which was basically unexpected, we didn't have so much possibility to diagnose cases. This is why the number of cases at this period was appeared to be small as compared to the total death and total ICU admission. And after basically the first patient was diagnosed on February 20, at that time, I think that for sure in Italy, I'm sure also in Europe, in US, I don't know, in Saudi Arabia, everybody was thinking that SARS-CoV-2 infection was a China problem. Nobody could have never imagined that that infection was already spreading worldwide. So much so, all of the sudden, out of the blue, during February 20, the first patient was admitted with a very strange interstitial pneumonia in a city close to Milan, in the north part of Italy, Cremona, who became quite famous. And the attending physician was an anesthesiologist who was he was not convinced on the etiology of the respiratory insufficiency. And since she was aware of the SARS-CoV-2 infection, she asked for a special test that at that time was available only in Rome, in the capital of Italy. And from then on, everything started. You have to imagine that during the first 7 days, every single day we had like 20 patients arriving at the hospital with a very severe respiratory insufficiency, basically looking for ICU admission. So basically in a couple of weeks, the north part of Italy had to double its availability of ICU beds. And after a few weeks, the government was wise enough at that time to decide for a national lockdown. And this is why we were able to basically to stop the first wave. We had more or less a relatively calm summer, But all of the sudden, starting from late August, and probably this was due to a lack of accurate control, everything started again. And right now we are in the middle of the second shock wave, and I can tell you that the number so far are not higher than the first wave, but for sure they will be higher than that. So we are in the middle of a very big and huge problem. This is your situation, actually. I was looking for that. And you guys, I think, started later during the end of March, as far as I have understood from the data of WHO. And you guys had a peak during the summer, but right now you are in a relatively good situation. And I hope for you that you will be able to maintain this situation. But of course, the numbers are extremely high, and this is it's really a striking fact. Now, I would like to start with some few premises, which I think are really important. First of all, we need to be aware that we are in front of an unknown disease. I'm smiling because if you look at PubMed, Medline, of course, there are tons of publications on COVID-19. It's a hot topic, we know that. But in all the publications, more than 50% are just opinions. Opinions, considerations, hypotheses, because it's really difficult to obtain evidence during an emergency time. And I think it's really important to keep this fact in mind. And also because we had to face as clinicians and also as a researcher, a very rapid wave of highly severe patients in need for ICU admission. And we need to keep in mind that publishing is not necessarily an evidence. As I said before, there are tons of editorials and review, but so far we have very few data on COVID-19, on SARS-CoV-2 infection, because it's still an unknown disease. And at least in Italy, and I was really struck by that, it happened in Europe for sure, and also in US. It was really strange to see how we lost especially in the first weeks of the pandemic crisis, we lost an evidence-based approach. We thought to skip all the common steps we are used to apply in order to understand things in medicine. And we started to test many different drugs. Think about tocilizumab, think about some antiviral drugs that later on turned out to be to not to have any effect or even to have some side effects on these patients. And this actually cannot happen again. We need to stick on what we have learned. We know that medicine is able to grow up based upon an evidence-based approach. So what I would like to do in the next 30 minutes, more or less, is to give you a general overview of what we know about this type of infection. I will show to you some of the main characteristics of the population we had in Italy and worldwide, at least for critical care patients. And I will go into more details about the need for a respiratory support, also keeping in mind the possible appropriate monitoring for this type of patients. And in the last part of my talk, I will just give you a brief summary of possible other important aspects on laboratory monitoring during the time course of this disease in ICU. And at the very end, I will just give you what we are doing right now, at least in my ICU and many other ICUs in Italy, on the monitoring of these patients and the clinical treatment applied on these patients. So we know that this is a coronavirus, and we know that it goes into the cells through the respiratory system and also through the gastrointestinal system. There are some data suggesting also a possible entrance through the endothelium, but we are not sure about that. We know that it's, of course, an RNA virus, and after replication and diffusion it becomes a real infection. But the big problem of this infection, and this is actually common to other coronavirus, is the inflammation generated by this type of infection. We know that starting from some sensor of the viral infection and some cytopathic effects of this virus, there is a huge inflammation which may be responsible, and actually which is responsible, at least this is our hypothesis, of the cell and organ damage we are facing in the most severe patients. And therefore, there is a strong interplay, because the first phase, which is the viral phase in which a patient gets the viral load and the virus gets replicated into the host. And then there is a huge inflammatory phases. And it's the interplay between these two phases which is responsible of the symptoms that the patient will manifest after the infection. And according to the type of interplay, the disease can get from an asymptomatic state. Right now, it's kind of strange because as compared to the first wave, we are seeing a lot of asymptomatic patients, which are not a big problem in terms of clinical problems, but of course they are a problem in terms of diffusion of the disease. Because if you can get an accurate control of asymptomatic patients, you cannot get a control of the disease whatsoever in the entire country. And the interplay I was saying between the viral phase of the disease and the inflammatory phase of the disease is responsible for the step up from a mild degree of the disease to a severe degree and the most critical phase of the disease. And of course, according to the degree of the disease, we may think and hypothesize also on the efficacy of some therapies. At the beginning, we were thinking that antiviral therapy was a good way to go. And later on, we started also to some antibody therapies. And of course, now the only therapy actually proved to be effective in this type of patients, and I will show you some statement on that, is an anti-inflammatory therapy, which may work, however, only in the late phase of the disease, not at the beginning of the disease. And according to the degree of the disease, it comes also the type of supportive therapies we need. Of course, the main organ damage is respiratory failure, we know that. And this is the main part of clinical treatment, of course, besides the etiologic treatment. And we may start from just oxygen, ending up to have the need for a non-invasive positive pressure, because this is the real problem, either high flow canal nasula or CPAP, and going towards an invasive positive pressure ventilation, and sometimes also for an extracorporeal membrane oxygenation. Now, but let's look at the evidence in terms of therapies, because I think it's extremely important, as I said before, to stick on evidence. And it's really amazing how the evidence are missing. At the beginning, I don't know in your country, but at the beginning, at least in Europe and in Italy, every single patient was treated with lopinavir, ritonavir. Now, the recommendation is against the use of this antivirus, because antiviral drug, because there's no actually evidence to support its efficacy. There is a strong recommendation against even the use of chloroquine and hydroxychloroquine plus minus azithromycin, because there's no data whatsoever supporting the hypothesis of its effective effect a beneficial effect on this disease. And there is even a recommendation against the use of ivermectin, which is an antiparasitarium drug for the disease for the treatment of this disease. And then going to the immunomodulators, there was in Italy a huge phase of immunomodulators. Everybody was thinking that tocilizumab was the main drug saving lives of COVID-19 patients, but this is not true. There has been at least a couple of randomized clinical trials suggesting that there's no effect, but actually there might be also the possibility of a side effect associated with these drugs. This is why the NIH recommend against the use of immunomodulators. anti-IL-6, interferons alpha or beta, as well as boton's tyrosine kinase inhibitors, and the same for Janus kinase inhibitors. No data supporting their use. And the same is true also for anakinra, which is an anti-IL-1 inhibitor. For this type of immunomodulator, actually, there are insufficient data to conclude either for or against its use. So it's still, it's still an open question, but we don't have so far data supporting its use. And the same, once again, is true also for convalescent plasma or immunoglobulins from patients got infected from this virus. And the same, it's even true for vitamin C, vitamin D, and zinc supplementation. No evidence whatsoever. Regarding the risk of thrombosis, so far there are some randomized clinical trials investigating this topic. We know that it's a hot topic because we know from a clinical perspective that this might be a huge side effect of this disease. But so far we don't have any evidence supporting the hypothesis of using an increased dosage of low molecular weight heparin as compared to just a venous thrombosis prophylaxis. The only treatment proved is more or less steroids, because of course there has been a large randomized clinical trial published on the New England Journal of Medicine concluding in favor of the use of remdesivir, with an advantage in terms of days of time course of the disease. But just a couple of weeks ago, there was a short communication from the WHO regarding the conclusion of another trial, which has not yet published, just stating that actually probably there will be no effect. So we will see regarding the use of remdesivir. Right now in Italy, we are still using it, and we are looking for the publication of these new results. But so far, the only real proved treatment is the use of dexamethasone, steroids, in the late phase of the disease, in the inflammatory phase of the disease, in the most severe patients. At the moment, every single patient under mechanical ventilation is receiving, or just under non-invasive ventilation, or even just oxygen, are receiving dexamethasone 6 milligrams per day for up to 10 days. And actually, this is just the only treatment we have in our hands. We need to support the patient, as we will see, with the respiratory support therapies, give some steroids, and more or less wait until the virus and the viral infection will get to a conclusion, and looking for and giving a lot of attention to the possible complications we are facing during an ICU admission. But this is just what we have in our hands. And at the very end, just to give you an idea of on the fact that this is an unknown disease, as you might remember at the beginning, everybody was talking about a cytokine storm. I'm sure that also in Saudi Arabia, everybody was listening to this hypothesis, this biological hypothesis. We know that there is a huge inflammation. Therefore, there might be a cytokine storm underlying COVID-19. Actually, look at this data. This is just a very recent meta-analysis published on Lancet Respiratory Medicine, focusing on articles investigating cytokines levels in different diseases of critical care settings. This is severe COVID-19. This is mild to severe COVID-19. This is ARDS. This is sepsis, and this is CAR T cell induced cytokine release syndrome. And look at the data. Actually, it's not true. Of course, IL-6 might be elevated in some patients, but it seems that there's no cytokine storm whatsoever underlying COVID-19 manifestation. And this is why probably we need to have another hypothesis on the possible development of organ dysfunction as compared to a cytokine storm. Maybe for sure there is an inflammation. We know that probably there is an activation of coagulation, but probably this inflammation is not mediated by cytokines. Now, let's have a look on which type of patients we are admitting in ICU. This is just the first publication of the first wave we had in Italy. We know that the median age was around 63, 62. We know that we had a huge prevalence of male sex as compared to female sex. And we actually, there are some data suggesting a protection in female sex regarding this infection. And we know that most of the patients has some comorbidities, not very severe, but the most common, like hypertension, diabetes, and cardiopathic ischemia. These are the most prevalent comorbidities we have observed in our patients. And we know that most of the patients admitted in ICU needed invasive mechanical ventilation, as we will see later on. Regarding invasive mechanical ventilation, we know that most of the patients manifested a very severe hypoxemia in terms of PaO2 and FiO2 ratio. And they had a huge need of high level of oxygen. And the same was even true for the level of positive end expiratory pressure, which is the positive pressure we have at the end of the expiration. I will show you also another large database from Italy, collecting 60 ICUs all over our country. The data I showed you before were concentrated in the first region that faced the first wave, Lombardy. These are more representative of the entire nation. As you can see, we have collected more than 1,800 patients admitted to ICU. And as you can see, we had the same time course of admission as compared to the entire nation. And look at this data. We had more or less the same observations. A prevalent of male sex. We had also a prevalent of patients with a not very high, but not normal body mass index. 30% of the patients had a BMI greater than 30. We observed the same comorbidities, hypertension, diabetes, and ischemic heart disease. And most of the patients, well, actually half of the patients arrived from a medical ward in the hospital because for the first days we were admitted to a medical ward and treated normally with a non-invasive support. But after few days, they get admitted in the ICU, while at least a quarter of them arrived with a very severe manifestation of the disease already at the admittance of emergency department. In terms of severity of respiratory insufficiency, as you can see, most of the patients has a PaO2 and FiO2 ratio lower than even 200 and even 100. So in terms of classification of ARDS, they showed a very severe ARDS. And in terms of organ failures at ICU admission, actually, they showed just most of them showed just respiratory failure. Some of them needed a very low amount of vasopressor, like norepinephrine, but not as a sign of cardiovascular dysfunctions, probably just as a consequence of sedation and paralysis due to the invasive mechanical ventilation. So most of the patients manifested just one single organ dysfunction. In terms of renal dysfunction, some of them actually manifested renal dysfunction, but this was related probably to a later admission in ICU as compared to the beginning of the symptoms. Here you can see also the severity of the systemic illness in terms of SAPS-2 score, so quite severe patients, and in terms of SOFA score, organ dysfunction failure. Let's have a look on the possible needs and support during the ICU. As you can see, most of the patients manifested an hypoxemic respiratory insufficiency. Hypercapnia, as you can see later on, was not a big problem in the beginning. And most of them just receiving invasive mechanical ventilation. Actually, in this cohort of patients, we observed a very small percentage of use of ECMO. I don't know in Saudi Arabia how many patients are in need of this type of support. Maybe we can talk about that later on. But at least in Italy, as opposed to what we have expected before, also based upon our experience on H1N1 pandemic, virus influenza pandemia, which was the previous pandemic we have faced, at least in Italy, the use of ECMO was quite small. And in terms of complications, we observed a quite low percentage of deep venous thrombosis and major event in terms of pulmonary thrombosis. But of course, this data probably is limited to the fact that we didn't standardize the way of looking for this data. So probably there should be some patients which develop thrombosis without any clinical manifestations. And this was a big problem, at least in Italy, the rate of secondary infections. And I will talk about that later on, but as compared to a normal population of ICU patients, we observed a quite high rate of development of secondary infections. And in terms of new organ failure, the most representative was renal failure and cardiovascular failure, although we didn't observe a high percentage of development of shock, as was actually reported in China from the first cohorts of patients reported from them. And more or less, we observed a quite long ICU stay as compared to similar patients with ARDS. And this actually was quite a big problem, because if you think about that, one of the huge social problems was the shortage of ICU beds. Of course, if you have a disease that lasts long, this could be an addiction, a problem addicted to the shortage of ICU beds. How about the respiratory support, which is the main problem of these patients? Why we need the respiratory support? Look at this blood gas analysis I got from a patient arriving to the emergency department just a few days ago in my hospital. 24 millimeters of mercury of PaO2. I'm not sure whether in Saudi Arabia you guys are using millimeters of mercury of kilopascal when looking at arterial partial pressure of oxygen. In terms of kilopascal is 3.2, so a very low level of oxygen. And I swear to you that this was an arterial blood sample. And this patient actually was not in respiratory distress. And this is a huge problem with this patient. They are arriving to the emergency department showing a very severe hypoxemia, even without symptoms. And look at this type of CT scan. This is let me see if we can, oh no, sorry, I didn't get it. Okay, look at this video. And this is why actually we need the respiratory support. I'm sure that you guys have seen patients like that. But this was actually a patient born in 1977, so was younger than me, which developed symptoms in 7 days. And he told us that he manifested just a respiratory distress the very same morning in which he decided to come to our hospital. And as soon as he arrived, we tried like half an hour with the CPAP, and after that he got intubated. And at this time, I think in the ICU is still in prone position, because there was no other way to treat his hypoxemia. So this is why we need the respiratory support. But the big problem of respiratory support is also that when we need to correct hypoxemia, of course, we need to apply a positive respiratory pressure, but the main problem is to avoid a possible damage. And therefore, we need to avoid the risk of lung injury due to high transpulmonary pressure. In other words, we need to avoid the risk of ventilator-induced lung injury, and more importantly, of patient self-induced lung injury. Look at this schematic representation, just to give you an idea of the problem. When we have, this is a normal patient in which normally we have 0 in terms of airway pressure, and we have a negative value in terms of esophageal pressure. The transpulmonary pressure is just 8 centimeters of water. This is the normal way in which we breathe. And the same is true when we have a patient under anesthesia. And the same is more or less true when we have a patient under surgery, for instance, during laparoscopy, in which we have the abdomen full of pressure, and we have an increase of actually a decrease of chest wall compliance, but the transpulmonary pressure is more or less normal. And the same isn't even true for a trumpet player, because when he blows the trumpet, there is an increase in alveolar pressure, but also an increase in the esophageal pressure. And this is why the transpulmonary pressure, which is the pressure across the alveolar wall, is still normal. But look at when a patient starts, even in spontaneous breathing, starts to breathe with a very severe distress. Since he has a very rigid lung, he applies a very high level of alveolar pressure, and due to his respiratory effort, he apply a very negative pressure in the pleural space. This is why even in spontaneous breathing, the transpulmonary pressure is even greater. And this transpulmonary pressure is applied to the alveolar wall. So this is why we need to put the lung at rest. And this is the main goal we need to achieve when we apply positive pressure ventilation, either in invasive methodology or non-invasive methodology. So the main goal is to avoid PSILI and VILI. There are a lot of literatures on that. We know that some of you are aware of this, and this is the main goal of mechanical ventilation, non-invasive mechanical ventilation and invasive mechanical ventilation. Now, in terms of respiratory support, we know that we may go from...
Dr. Petro, can I just stop you
Sure.
for a while? Just notice that we will be receiving questions which are written in the whiteboard. So please, if you have any question, send it to the whiteboard or Q&A, either in English or in Arabic. We will translate it if it is in Arabic. There will be no question recorded by voice there will be no question by mic. Dr. Petro, sorry.
Okay, great.
Yeah.
No problem. So as I was saying, the respiratory support goes from just pure oxygen in mask through non-invasive positive pressure ventilation, either in high flow canal nasula, which is this type of device, or in CPAP. We are used to apply CPAP with an helmet, going towards an invasive positive pressure, and at the very end, ECMO, extracorporeal membrane oxygenation, venous to venous side. Now, I have also added here prone position because there are some in the middle of non-invasive and invasive positive pressure, because there are some data, and we have at this moment quite a huge experience on the application of prone position also in when we have a patient not intubated and just with an helmet. It's possible. We know that we get an improvement in oxygenation. We don't know yet whether the application of this position may somehow avoid the development of the most severe manifestation of the disease. This is, of course, is one of the main points we need to investigate. But so far, it's a quite good maneuver as a rescue therapy. Now, what to look in terms of respiratory support? Of course, the most important parameters is PaO2, arterial partial pressure of oxygen. I'm sorry if I summarize some very basic concept of oxygenation and carbon dioxide dynamics, but I think are important to keep them in mind in order to treat this patient. So we know that why PaO2 is important, of course, because it's the tension that lead to the link of oxygen to hemoglobin. And why hemoglobin is important? Because it's the way in which we are able to transport oxygen to peripheral organ. This is the common equation describing oxygen delivery. And this is the main fuel we have for our organs. So if you imagine that the patient I was showed before had a value of PO2 of 24, you can imagine that his oxygen delivery was impaired, so much so that in that blood gas analysis, as you might have seen, the lactate level was 10. So that patient was in failure of oxygen just due to the very severe hypoxemia related to COVID-19. But we are used to monitor oxygenation using a ratio, PO2 FiO2 ratio. I'm sure that also in Saudi Arabia, you guys are used to this ratio. Why? Because it's a very common way to standardize the value of PO2 according to the inspired oxygen fraction. I might have the same value of PO2, for instance, 100 millimeters of mercury, either if I'm breathing just room air or if I'm breathing 100% of oxygen. It depends on how my lungs are injured. And actually, the use of PO2 FiO2 ratio comes also from the last definition of acute respiratory distress syndrome. As you might remember, in that definition, finally, after after the previous definitions, the severity of ARDS was stratified according to this value. So a value lower than 100 was identifying the most severe cases of ARDS, between 100 and 200 millimeters of mercury moderate ARDS, and between 200 and 300 mild ARDS. This is why we are used to apply this ratio. But we need to keep in mind that actually the most important parameters, and I'm sorry that in Italy we are basically losing the ability and the memory to use this parameter, is the calculation of shunt fraction, which is the only way to really have a number telling us the real severity of the lung disease, of the lung injury. Why? Because if this is another CT scan of a COVID-19 patient, as you can see here, we have some regions of the lung which are not aerated. This means that the perfusion of these areas arrive to the heart just as venous blood. And this is the concept of right to left interpulmonary shunt. Now, it's possible with the blood gas analysis to measure these parameters. And from this measurement, we are able to say that, for instance, 30% of cardiac output basically is passing the lung without receiving new oxygen. And why it's so important to have in mind that this is the most accurate parameters describing lung injury? Because if I have a lung collapsed, I might be able even to increase inspired oxygen fraction, but that oxygen doesn't go and doesn't open the lung. So look at this graph. Here is the inspired oxygen fraction and the resulting PaO2 according to different amount of oxygen shunt fraction. When I have half of the lung collapsed, I might be able to increase oxygen even to 100%. The PaO2 will not change. Why? Just because the oxygen arriving to the lung will not be able to open up the lung. Unless I will apply a positive pressure, just the application of a high value of inspiratory oxygen fraction doesn't change blood gas analysis and doesn't correct hypoxemia. This is why it's so important to have in mind these parameters. And it's possible just from a venous blood sample and an arterial blood sample to calculate these parameters. All the blood gas analysis machines are able to do that. It's a common setting that it's important to have in our hands. And this is the formula we are used to apply. And actually, blood gas analysis applies for us because we are not able to keep this formula in our hands and in our mind. So it's easier to use blood gas analysis. machines. And the last parameter is important in terms of monitoring respiratory failure is arterial partial pressure of carbon dioxide. Now, we know that PaCO2, carbon dioxide, is something strictly related to alveolar ventilation, which might be another huge problem when we have very severe respiratory insufficiency. But in this type of respiratory insufficiency in COVID-19, it's important to have in mind, and I think it's also your experience, that in the first phase, hypercapnia is not a problem. The real problem is hypoxemia. This type of patients arrives to the hospital very hypoxemic, not hypercapnic. Most of the times are hypocapnic because they have a very important hypoxemic stimulus to breathe. In the late phase of COVID-19, when possibly the disease might also turn into lung fibrosis with an increase in alveolar dead space, in this type of phase of the disease, hypercapnia might be a problem. So the monitoring of arterial partial pressure of carbon dioxide, I would say that is important in the second phase of this disease. Just a couple of interesting insight in terms of respiratory support, just to have an idea of the possible differences between ARDS and COVID-19 respiratory failure. First of all, at the beginning, we were wondering whether COVID-19 and SARS-CoV-2 infection was similar to ARDS. Now, there has been a huge debate and even a fight between different researchers regarding this topic. And this actually an editorial published together with Luciano Gattinoni, which is one of my mentors, actually who is my first mentor, and showing and suggesting the hypothesis that actually we might have two different phenotypes in COVID-19 population. We may have a phenotype called defined type L, which is this one, in which we have a low lung elastance, therefore higher respiratory system compliance. The lung is distensible. We have low VRQ ratio, a very high level of mismatch. The lung is almost normal, and we don't have any, as you can see, we don't have any, let me just get the pointer. We don't have any atelectasis to be opened. But at the same time, we have the same level of hypoxemia. So this means that in this phenotype of COVID-19, there is a huge amount of VRQ mismatch and not intrapulmonary right to left shunting. While in another phase and another phenotype of the disease, COVID-19 patients appear more similar to ARDS patients, as you can see here. As you can see, we have the same level of hypoxemia, but due to a different mechanisms. This type of patients, type H, has a high lung elastance, meaning a rigid respiratory system, a stiff respiratory system. They have a very high amount of right to left shunting, a very high lung weight, and high lung recruitability. Applying positive pressure, we are able to open up this type of atelectasis. And once again, what was striking at the beginning when we wrote this editorial was to notice that the level of hypoxemia was quite similar between these two completely different phenotypes of COVID-19 patients. And actually, the type L phenotype is just characteristics of COVID-19 patients population. But a second aspect that is important to keep in mind, and I'm sure that more investigations are needed to clarify even better this aspect, is the possible role of a second hit on the lung, which is the possible thrombosis, microthrombosis of the pulmonary circulation. This is another important article comparing a population of COVID-19 patients with an historical cohort of ARDS patients. And as you can see, these investigators were able to perform lung angiogram in order to evaluate lung perfusion. And as you can see here in all the purple color, the purple color denotes regions of the lung with very high hypoperfusion, suggesting therefore that in some type of these patients, we may have problems in lung perfusion on the top of problems on lung ventilation. And actually, when they try to combine these two heat of the lung injury, looking at the level of D-dimer as a sign of thrombosis, they observed that patients with a very high level of thrombosis, high level of D-dimer, as associated with a stiff respiratory system, therefore a low lung compliance. These type of patients showed the high mortality as compared to all the other three groups, suggesting therefore that in this type of patients, maybe an anticoagulation might be a good solution. But of course, the level of D-dimer is extremely important in terms of monitoring. Now, let me just give you a brief summary in 5 to 10 minutes of few other aspects. First of all, which are other important laboratory parameters in this type of patients? This is just a suggestion, but I think reflects our common daily practice on this type of patient. Of course, a number of parameters describing lung inflammation. Lymphocytes, of course, ferritin, PCR, and LDH. And what is important is to follow the time course of these parameters during the ICU stay. Of course, we are in every single day measuring the dimer fibrinogen, also as a sign of inflammation, and the dimer also in order to be able to get the possible development of thrombosis. And another important aspect is the monitoring of the development of co-infection, of bacterial co-infection, using a biomarker which is procalcitonin. And I think this is one of the huge problems we are facing on the top of the very severe respiratory insufficiency that we get at the very beginning. Why? Because well, there are some considerations to be made, but the most important problem is that you need to imagine a highly inflammatory context of these patients. And in this highly inflammatory context, which is strictly related to COVID-19, it's almost impossible, or it's extremely difficult to get the diagnosis of a possible superinfection, bacterial co-infection, because it's a completely different patient as compared to a common ARDS patient. We know that it's quite difficult to obtain a variation of CRP not related to COVID-19, but related, for instance, to a bacterial infection. We know that sometimes the possibility of individuate the organ site responsible for the co-infection is difficult, because we have, for instance, in terms of ventilator-associated pneumonia, we have a lung already injured. And we know also that the timing in which we are facing the patient might be different. We actually, when a patient arrives to the emergency department, we are not really sure when the infection started. This is why it's quite difficult to be sure of the phase of the disease we are facing during the treatment of that patient. But why this type of patients may have an increased risk of co-infection? Well, first of all, because we know that every single viral infection may induce immunosuppression. And this is why these type of patients have an increased risk of co-infection. The second reason is that we are using, as I said before, therapies that may interfere with the effect of immune system, such as steroid therapy and immunomoderating therapies. Now, so far, regarding steroid therapy, we don't have any data supporting the hypothesis that the use of steroids may increase the development of acquired infection. So we are lucky in that. But for sure it's another important risk. And as a third aspect important is this one. This is just a picture of the second ICU we had to open up in my hospital, just invading coronary unit. It's an old-fashioned word, but this was the location of the coronary unit. Now, when you have patients treated in the same room, of course, the risk of co-infection between one patient to the other is extremely high. This is why this type of patients may have a secondary risk of secondary infections. Actually, there are some data supporting this hypothesis, and some of them are not of a good quality, but this is a quite good quality database just published on intensive care medicine, supporting the hypothesis that this type of patients have a relatively high risk of secondary infections. Here, about 20% of the patients developed secondary infections. And this is our data, as I said before, of the 60 ICUs collected in Italy. And as you can see, we observed a relatively high incidence of ventilator-associated pneumonia and a relatively high incidence of catheter-related bloodstream infection. So these are secondary infections that added to the patient and increase the risk of death. So if we are not able to detect very rapidly this type of patients, it's a huge problem. And this is why it's so important to use a biomarker in order to detect co-infection. And this is procalcitonin. Look at this graph. This was a lady we had in our ICU, admitted for respiratory insufficiency failure due to COVID-19. And one night in the afternoon, he started to develop a fever. But we know that fever may be another manifestation of COVID-19, but we were not sure that there was no co-infection on this type of patients. And therefore, we added a laboratory examination point during the night. And this is the level of procalcitonin just during the night. So based upon this type of variation, we decided right away to start with antibiotics, and we were able to prevent and to treat very rapidly a very severe septic shock that lady developed during the following 2 days. This is why, well, this is important for every single ICU patient, but in this type of patient might be extremely important. And I will get to the conclusion. Sorry?
Yeah, we are a couple of minutes away from finishing.
This is just the last slide in which I'm going to show you and to suggest what we are doing in our ICU and actually most ICU in Italy in terms of monitoring during the daily life of an ICU patients with COVID-19. Of course, at ICU admission, in addition of a complete picture of the patient, we are focusing on the possible diagnosis of bacterial co-infection, because one of the big problems is that these patients might have also a community-acquired pneumonia. We know that they are positive in terms of SARS-CoV-2 infection, but since they come from the community and since they come with respiratory symptoms, we need to confirm or to be sure that these patients don't have any bacterial co-infection. This is why we apply a lot of laboratories examination in order to exclude this possibility. On a daily practice, we continue to monitor this type of parameters, as I told you before, and on a weekly basis, we are monitoring the possibility of colonization, because this is a most important aspect in terms of be able to rapidly get the development of a secondary infection. And in case of suspected co-infection, of course, we added more examinations. Thank you very much for your attention.
Many thanks, Dr. Petro, for this very nice and informative lecture. And as we said, there will be 10 to 15 minutes for a question and discussion. If you have any question, please send it to Q&A or send it to the chat. I have a question from Hadi Al-Makdi. He said, have you ever recorded case of AIDS patient infected with COVID-19?
HIV patients?
HIV, yeah.
Okay, no, as far as I know, we didn't have any higher prevalence of HIV patients getting COVID-19 infection, but it's true that some patients with immunosuppression, we had a relatively high prevalence of oncohematologic diseases leading to immunosuppression, and I can tell you that these patients have an increased risk of develop a very severe manifestation of the disease.
Thank you. And there is a question from Dr. Zuhair Awan. How about COVID-19 and cardiovascular disease? Is the incidence higher?
Well, this is an important question. I didn't have the time to, of course, to talk about that. Well, actually, it's true that COVID-19, one of the possible organ dysfunction due to COVID-19 might be also cardiovascular dysfunction, especially in terms of myocarditis. There has been some few cases actually with the less than 5% of all the cases, but showing myocarditis and an impairment of cardiac contractility. It's important to keep in mind, however, that the need for vasopressors, which is commonly reported in many clinical series, is probably related most of the time to the sedation needed for the invasive mechanical ventilation applied, rather than for as a sign of cardiovascular dysfunctions. But it's true that COVID-19 might also affect cardiac contractility.
Mm-hmm. Thank you. There is a question in Arabic. I will translate it as much as I can. He asked, is that true? There is a selection between patient for giving them intubation or respiratory, especially in the beginning, maybe in the beginning of the service, in the beginning of the crisis. I think we were discussing yes. That before the.
Well, yeah. I think it's extremely important while difficult question, because especially, at least for Italy, especially during the first wave, and actually even now, actually we have really tried to do our best in order to increase ICU availability. As I told you, in Italy during the first wave, we had to double the ICU availability. How? Just basically invading operating rooms and coronary units, for instance. And as much as we were able to do that, I think that most of the time we were able to treat the most appropriate patients that in which we had a higher chance to get an advantage of the treatment applied. But it's true that especially when a rapid pandemic arrives to you, it's true that maybe you are not aware of doing that. But when you have, for instance, just one ICU bed and you have 4 patients that might get an advantage of intubation, now in that case, the problems start. And we are trying to do our best, but I'm quite sure that this might be a problem.
Yeah, I think it's an ethical, debatable issue.
Absolutely.
A question also from Ranim Qasim. What is the difference of the new generation of COVID-19 or the second wave? I think she asked about the first wave and the second wave. Is there a difference between these two generations?
It's an important question. Actually, so far, in terms of my experience, because at least for us, it's too early to have some, data in order to answer to this question. But in terms of experiences, we are not seeing so much differences. We need to keep in mind that during the first wave, at least in Italy, and I'm sure also in Europe, more patients than now were more or less treated with a mild form of the disease at their home, not in the hospital. Now we are seeing many more patients with mild manifestation of the disease just because patients are scared, because now they know what COVID-19 is, and therefore they go to the hospital, while before, during the first wave, at least in Italy, they were staying at home. So this get the feeling, probably the wrong feeling that we are seeing more patients with a mild disease. But if you look at the number, basically we don't see any difference in terms of time course towards the most severe cases. So much so that now we are basically more or less at 3/4 of the top high number of ICU beds we had during the first wave. So I think it's too early to get a good answer to this question.
Yeah, thank you. From Nader Agil, is the D-dimer elevation confirmed the PE in COVID-19 patients since cannot do the CT scan, and what is the management of that cases?
It's a very important question. Actually, I told you that according to the international guidelines, there are no data supporting the hypothesis of increasing the dosage of heparin as a thromboprophylaxis. Now, in Italy, most of our ICUs and even my ICUs are anyway increasing up to 50% of the normal dosage of heparin, just because the problem is that when we had a few cases of cardiac arrest, sudden death due to massive pulmonary embolisms. So therefore, since the consequence is might be very tragic, we decided to accept the risk of increasing the level of heparin. Now, my suggestion is that if a patient cannot do a CT scan in order to screen for thromboprophylaxis, in our ICU, if we see a D-dimer level going with a wide variation as opposed to the previous level, we are starting to anticoagulate that patient because the risk is extremely high of side effect. But I'm saying what I'm saying, being aware that it's out of standard guidelines, because so far there are some randomized clinical trials trying to answer to these questions. So I just take away the cap of a scientist and I'm just giving an advice in terms of experiences.
Thank you. Farsal Gahtani said some COVID-19 patients do not focus on the respiratory system. I think he means there will be no problem in respiratory system. He said, is immunity a reason for this or behind this?
You know, I like to imagine that this might be a good hypothesis, but so far we don't have any idea of that. And I can just tell you regarding a patient we had in our ICU, which was with multiple myeloma. So his immune system was not able to build antibodies to the virus. Well, this patient gets the infection. He got the pulmonary, the pneumonia. He recovered from pneumonia, and he still had the virus without any antibodies. And the virus was not doing anything more than as compared to what he had previously. So it's really strange, the interplay between the immune system and the virus in some type of patients. So it's true that some patient doesn't manifest any symptoms, but we don't know yet why.
Okay, we have a lot of questions, so we will give it another 5 times. So please, 5 minutes, sorry. So could you please, Dr. Petro, to answer as fast as possible?
Yeah, I'll try.
There is the question about Ashraf Barakat. How much PEEP limits can apply during invasive ventilation?
The minimal level you can in order to obtain a good oxygen. So this is quite important. The hypothesis is the opposite to what we are used to think regarding ARDS. Higher PEEP and low inspiratory oxygen fraction. For COVID-19 is precisely the opposite. So 10 to 15 at last.
Mm-hmm. Thank you. I think this is maybe $1 million, as they said, question. It's written in Arabic, and I think it will be written in English and all over the country, all over the world, different language. Is there a possibility to have another episode or another infection after, if the patient had it before, had the COVID-19 before?
I have no idea. Actually, a colleague of mine, get the infection. She was positive with antibodies. Now she doesn't have any antibodies anymore. So
no idea. You lost the $1 million, Dr. Petro. Sorry.
Okay. Yeah, right. I'm sorry.
What about the differences in the genetics polymorphism in Italian COVID-19?
There has been a very important publication on New England Journal of Medicine suggesting the hypothesis of a possible link between even some components of blood, AB0 component of blood, but these are just preliminary data. So we don't have so far any strong data supporting a genetic link.
That was a question from Dr. Mohammed Dathibeti. He is a geneticist here in Saudi Arabia. Is there a recommendation about soluble receptors, interleukin 6 and FOG19?
No. I think tocilizumab. Yeah. No, as I said before, according to the international guidelines, we do not have to use this type of drug in these patients.
Yeah, a question about the severity of reinfection of COVID-19. We heard that it is more severe, this case will be more severe with the second infection. And as you said, there is no idea. There is a question about the rooming about manufactured or normal. Are believed to the virus, is it normal or manufactured, or I mean, it's previously made, or it's not natural?
Oh, the virus? No, I mean, no. Another advice I think it's important to have in mind is guys, just stick on scientific literature, because if we are starting to stick on socials, Facebook and whatever, I mean, no, science gets lost. So sorry about that, but it's important. Yeah.
Okay, another 2 minutes. Some COVID-19 patients do not focus on the respiratory. This is written. He repeat the question. And there is a question also about the vaccine and the Pfizer. I think they have announced that 2 days ago that they are in the last phase of. So this is from Fouad Al-Anizi.
Well, yeah. I don't know much on vaccination because it's not my topic, but I really hope that we will get a vaccination, because otherwise, I mean,
of course. You will be in trouble with the ICU.
Also, I mean, everybody will be in trouble. So, of
course, yeah. Okay.
But I think that it will be available. I think we will have extra months to fight against the COVID-19 before having a good vaccination.
Okay, we'll give it another last question. Relation between smoking and COVID-19?
I'm aware of some publications supporting this hypothesis. In all the good and large cohorts of patients, actually, however, there was no strong signal. So I think it's not so true.
Yeah, I think we run out of the time. Now it's 8:19. So at the end of this lecture, we would like to thank you very much, Dr. Petro. It's our pleasure to have it this nice, and I think it was very informative lecture. Hopefully we can see you in another events, hopefully inshallah here in Saudi Arabia, not visit virtually, visit actual visit, inshallah. You are most welcome, and thank you for all the participants. We have now 505 participants who viewed this very informative lecture. Thank you very much, and thank you for Abdulla Fouad for organizing this, and for also for the Saudi Association of Clinical Chemistry for also organizing this lecture and supporting it. Thank you.
Thank you very much, and good luck to everybody, actually.
Thank you, doctor. Thank you.
Thank you. Thank you, everybody. Have a good evening, and hopefully we'll come up with more information to share in the future. Thank you, Dr. Cayoni, Dr. Said.
Thank you.
Bye-bye.
Bye.